Hello students, today we continue to study our course and today's lecture is percussion of the lungs, comparative and topographic percussion of the lungs. So previous lecture you study such physical method of like palpation. Today we will talk about percussion. So few words about history. Yeah. So percussion, it goes from the percutere, so from French. So it means to strike through. So percussion means to strike through. So this method of this physical method was found by Austrian physician Auenbrugger in 1761. So a few words about this, about history of this method. So how Auenbrugger find this method. So his father, he was winemaker, and when Auenbrugger was a child, he looked for his father and see such things that his father make strikes for barrels with wine to find is wine is ready or not. And when he becomes a physician, he remembers these things from his childhood and started to use such method. And he finds that our body has different sounds. And in these findings, he finds method of percussion. So, in percussion, your finger functions as a hammer, and the vibration is produced by the impact of the finger against underlying tissues. Sound waves are heard as percussion tones that arise from vibration 4 to 6 centimeters deep in the body tissues. The degree of percussion tone is determined by the density of the medium through which the sound waves travel. So this is physical methods of percussion, so physical characteristics of percussion. So percussion tones, it can be tympanic tone, hyperresonance, resonance, dullness, and flatness. So if you try this method at home, you can make strokes on different things. So if you make strokes on the table, you can hear dull sound. If you make strokes on the bottle of water, you will hear another sound. So different physical characteristics of the tissue, different strokes will make different sounds. So tympanic sound, it is loud, high, and drum-like. Hyperresonance, very loud, low, and booming. Resonance, loud, low, hollow. Dullness, soft, moderate, thud-like. Flatness, soft, high, and dull. So our body, you see on the pictures, front side, back side, and sounds. So where we will hear different sounds. So first of all, lungs. So lungs, it is tissue with air. And if we make percussion under the lungs, we hear resonance sound. So then heart, liver. So heart, liver, it is organs without air, So parenchymal organs. So if we make percussion on the liver or on the heart, we will hear dullness, cardiac dullness and liver dullness. So next our organ is stomach. So stomach, it is muscle hollow organ. So hollow. If we make percussion under the hollow organs, we will hear tympani. So stomach, tympani. What else? If we look at our backside, so we have scapulars, heavy muscles. So if we make percussion under them, we will hear flat. So flat or absolutely dull sound. So this is different types of sounds in our body. Our percussion can be direct or indirect. So, direct percussion involves striking the soft tip of the index finger directly against the examined part of the body. Indirect percussion, the finger of one hand acts as a hammer and the finger of the other hand acts like striking surface, deximetry. So on the picture you see direct percussion and indirect percussion. So in direct percussion we use only fingers and make strokes. In indirect percussion we use two hands, so one hand, and we stroke fingers on the fingers of the another hand. So indirect percussion. Direct percussion is used in pediatrics to make percussion for the child. In internal medicine, we use indirect percussion, and on your practical lessons, you will learn how to do indirect percussion. So, physical characteristics of tapping. So, tapping strength. It can be loud, light, and lightest. So, as more heavier strikes you make, more loud sound you will have. So if you hear, I make some different strokes, and the sound is in different volume. So to make loud sound, so we use normal force of the tapping. So to use loud percussion, we examine deeply located organs. Light percussion is used to determine the signs and the borders of various superficial organs, liver, lungs, and the heart. Lightest percussion is used to determine absolute cardiac dullness. So, tapping strength, so such physical characteristics. Let's talk about percussion. If previous slides was about percussion as method, so now we will go to the percussion of the lungs. So percussion of the lungs, we start with comparative percussion. So first we percuss chest, anterior part, lateral part, and posterior part. Compare tones bilaterally on the symmetric parts. After comparative percussion, we make topographic percussion, and after topographic percussion, measure diaphragmatic excursion. Main rules of the percussion. As you see on the slide, this is the important rules. So, patient should be in the comfortable posture and relaxed. The room should be warm and protected from the external noise, because if it will be noisy, you can't hear normal sounds. The physician should be also in a comfortable position as well. Physician's hands should be warm. The middle finger of the left hand pleximeter should be pressed tightly to the examined surface. The neighboring fingers should be somewhat set apart. So if you don't press your finger tightly to the chest, the sound will be changed and it will be different sound than normal. The downward snap of the striking finger originates from the wrist and not the forearm or shoulder. So in percussion, you make strokes only by your wrist. The tap should be sharp and rapid to prevent damping of the sound. Tapping should be uniform. The force of the percussion strokes depends on the object being examined. So this is main rules of percussion. So as you look at the picture, so first of all, we start from the comparative percussion, and comparative percussion we start from the anterior part, and we start from the lung apices. So we make strokes on the right side, then on the left side. So strokes we make in the intracostal spaces. So your finger pleximeter also should be placed in the intracostal spaces. In this case, we percut apexes of the lungs, so we put our finger pleximeter over the clavicula, and with our right hand we make percussion moves. So right side, left side, and compare sounds. The sound should be equal in the both sides. Our next step is percussion over the clavicula. So clavicula, it is costal structure, so it works like pleximeter. So when we make percussion over the clavicula, we don't use pleximeter, so we make strokes directly on the clavicula, on the right part of the body and on the left part of the body, and compare the sounds. After this, we continue to make percussion on the front side of the body and make comparing of the sound in the right part and on the left part. After clavicula, we go on through the intracostal spaces. Second, third. So, what is important to remember? So, when we compare sounds on the anterior part, I remember, we make percussion over the clavicular, on the clavicula, and then on the intracostal spaces. Right, left, right, left, right, left. But starting from the third intracostal space in the right part of the body, we have heart, as you see in the picture. So in this case, we can't compare right part of percussion and left part of percussion. So what we do, how to compare? When we go on the fourth intracostal space in the right part of our body, we compare it in the third intracostal space in the left part. So we compare intracostal spaces to the heart dullness, then we compare right part to the third intracostal space in the left part of the body. Next step, percussion of the axillary region. So we ask patient to put his hands over the head and make percussion on the right lateral part and left lateral part, and also compare the sounds. As you look at the picture, so right part of the body and left part of the body. So remember also that your finger should be placed in the intercostal spaces. Next, our step, so percussion of the suprascapular areas. So as you see in the picture, we make percussion over the scapulas, suprascapular area. We put our finger in the, again, right part and left part of the back side, and also make percussion moves and compare sounds. After percussion of the suprascapular region, we need to make percussion between the scapulars. Something you need to remember in the percussion between the scapulars, we put our finger fleximeter vertical between scapular and spinal column. So because in this place we can't put our finger horizontally because this space is too short. That's why we put our finger vertical and make percussion in the region between scapulars and compare also sounds in the right part and in the left part. And the last step of comparative percussion, percussion of the points lying below the scapula. In this part we put our finger again horizontally and make percussion and compare again sounds in the left part and on the right part. So again, you see on the picture. So first it is suprascapular region. You see that fleximeter, finger fleximeter goes horizontally, and doctor make strokes on this finger. Then percussion between scapulars. We changed the position of our hand and over position under the scapulars. So when we make percussion of the back side, so we ask patients, patient's head bent forward and arms folded in the front to make place more wider where we make percussion. So what we can find in comparative percussion of the lungs? So normally in all areas of our lungs, we should find resonance sound. So resonance sounds, it is normal sound of our lungs. What we can find abnormal? So we can find hyperresonance, dullness, or tympanic sound. So hyperresonance indicates hyperinfiltration of the lungs. Dullness indicates construction of the lung tissue, and tympanic sounds indicates presence of some cavities or air in the lungs. So if you remember previous lecture, so you see such pictures, we checked vocal tremor or tactile fremitus. So now this picture shows you sounds of percussion. So tympanic sounds can be due to pneumothorax. So you see lung in the right part of the picture. So air in the pleural cavity. So sounds become tympanic. Next picture, cavity with air. So such disease like tuberculosis, so cavity in the lungs. So if we make percussion on this cavity, so sound will be also tympanic. So hyperresonance. So hyperresonance due to emphysema. So emphysema, you remember previous lecture, barrel chest. So, and if we make percussion, hyperresonance sound. Dullness. So what can be the reason of the dull sound? So fluid pleuritis, so accumulation of the fluid in the pleural cavity. So if we make percussion over the fluid, the sound will be dull. Next one, inflammation, consolidation of the lung tissue. So pneumonia, if we make percussion over the pneumonia, it will be dull sound. Next one, pleuritis, dry pleuritis, so inflammation of the pleura. Also, if we make percussion here, it will be dull sound. So if we make conclusion of these cases, if we make percussion over the air, of the accumulation of the air in some pleural cavity or in the cavity in the lungs, under this air, it will be tympanic sound. So if we make percussion over the inflammation or consolidation of lung tissue or water, it will be dull sound. So emphysema causes hyperresonance sound. So please remember this. Next sound, what we can find during percussion. So dull sound with tympanic tone. So in which cases it can be? So you see on this picture pleuritis, so accumulation of the fluid in the pleural cavity. So here we will hear dull sound as we mentioned in the previous picture. But in the upper parts of the lung, so it will be compression atelectasis, so our lung is pushed up, and in this case it will be dull sound with a tympanic tone. On the picture you see why, because we have air and consolidation of the lungs. So air and tissue. It will cause dull sound with a tympanic tone. After comparative percussion, our next step is topographic percussion. So topographic percussion is used for determining the upper borders of the lungs or apices and the within, so upper borders of the lungs and apices of the lungs and within chronic area. The lower borders of the lungs, it is second step, and third step, mobility of the lower border of the lungs. So first our step, percussion of the upper anterior borders of the lungs. So how to make this percussion? We ask patient to put, if we start from the right part of the body, so we ask patient to put his head in the opposite side, as you see on the picture, and make percussion. Put our finger over the clavicular and make percussion up. So we make percussion from the resonance sound to the appearance of the dull sound. Where a dull sound appears, we put mark and it will be upper border of the lung. upper posterior borders of the lungs. So as you see on the picture, we ask patients to put his hand in the front and start percussion again from the scapular. We go to the up, and again we make percussion from the hyperresonant sound to the dull sound. Wideness of the lung apexes or chronix area, as you see on the picture. So doctor stands on the back side of the patient, put his finger on the apexes of the lungs and make percussion from the middle to the right and to the left. And now we find again, we make percussion from the resonant sound to the dull sound. It will be wideness of the lung apexes or chronix area. So changes. Apices of the lungs can be increased when the amount of air is high. Again, the reason is emphysema. Apices of the lungs can be decreased, so presence of the connective tissue or inflammatory infiltration. In this case, apices of the lungs become decreased. Next step, we find lower borders of the lungs. We need to find lower borders of the right lung and lower borders of the left lung. How to find it? So we use all topographic lines of our lungs. So starting from parasternal line and ending with paravertebral line. So we start from the right lung. So the pleximeter finger is placed in the interspaces parallel to the ribs. Percussion usually begun anteriorly from the second and third costal intercostal spaces. So we put finger and make percussion and go down. So percussion again we make from the resonant sound to the appearance of the dull sound. So we start from the parasternal line, then medial clavicular line, axillaris anterior line, and so on. After we make percussion of the anterior part, we go to the lateral part. You see pictures. And posterior part of the body. So we make percussion on the anterior part on two lines. Parasternal line, medial clavicular line. In the lateral sides, we make percussion on the three lines. Axillaris line, so axillaris anterior line, axillaris media, axillaris posterior. And on the posterior part, on the back part, we use scapularis line and paravertebral line. So, and on the picture you see normal borders, lower borders of the lungs. So right lung, parasternal, it is 5th intercostal space, medial clavicular, 6th intercostal space, anterior axillary line, 7th, mid-axillary 8th, posterior axillary 9th, scapula 10th, and paravertebral spinous process of the 18th thoracic vertebra. If you look at the left lung, you see that we don't have lower borders on the parasternal line and mid-clavicular line due to heart dullness. So we can't make percussion of the left lung on these two lines because of the heart which is situated in this part of our body. So if we need to make percussion of the lower borders of the left lung, we start percussion from the axillaris anterior line. So changes, bilateral changes, so can be due to acute and chronic dilatation of the lungs, sudden weakening of the tone of abdominal muscles, lowering of the abdominal viscera, splanchoptosis. Unilateral can be due to compensatory or vicarious emphysema of one lung with indication of the inactivation of the other lungs. So it is lowering of the lower borders of the lungs. Elevation of the lower borders of the lungs, usually it is unilateral, occurs in pneumosclerosis, atelectasis, accumulation of fluid or air in the pleural cavity, marked enlargement of the liver or of the spleen. So this is elevation of the lower borders of the lungs. So, and the third step of topographic percussion, and the last step of percussion, so we find measure of the diaphragmic excursion. So we need to find how lower border of the lung moves in inspiration and expiration. So what we do? Usually to find measure of diaphragmatic excursion, we use axillaris media line. So first step, as it was in topographic percussion, we make percussion and find lower border of the lung on the axillaris media line. After we find this border, we make mark on the patient chest and ask him to take deep breath in. So I remember you that we make our percussion from the resonance sound to the dull sound. So after patient takes deep breath in, his lungs become wider, and in place where we have dull sound normally, now it will be also resonance sound due to enlargement and movement of the lungs. So we make again, we start percussion from the resonance sound to the dull sound. And after this, when we find again dull sound, we make second mark in the chest of the patient. Yeah. And after we make make percussion on the breathe in, we ask patient to take deep breath out and make percussion to the up. So in this case, we will make percussion from the dull sound to the appearance of resonance sound. So 3 steps. First step, find normal lower border of the lungs. Second step, find border in the deep breathe in. And third step, to find lower border on the deep breathe out. When we find third step, we make third mark. And to check diaphragmatic excursion, so we take centimeter and make and see how many centimeters it is from second mark to the third mark. So normal diaphragmatic excursion in the patients, in the healthy people, on the healthy patients, it is 6 to 8 centimeters. So that was the last step of percussion. So thank you for your attention.